Thank you so much. First of all the organizers. I had an opportunity to listen to very interesting talks since morning, especially related to pharmacovigilance and also the materiovigilance that I'll be talking about. So this topic is of interest to me because besides being a surgeon, I'm an innovator and working on a lot of devices. We have been funded by a number of organizations, and I'm pretty sure a lot of surgical friends. I can see 44 participants who are currently listening to the talk, and I'm pretty sure there are a few surgical residents and orthopedic residents also from my alma mater, which is NHL Municipal Medical College, where I graduated and where I did my MS from. Before starting this talk, I'd like to just come up with a few disclaimers that I have. I have been funded by Canada India SCI Innovation Award for developing artificial muscles for tetraplegic hands. I've been funded by Spine Asia Pacific Award for developing neuromonitoring in spinal cord injuries and spinal cord surgeries. I'm working at Indian Spinal Injury Center currently, and also at Amrapali and associated hospitals, being a consultant. And I'm thankful to my mentors from UCMS, where I did my M.B.B.S, NHL MMC, Dr. Harsha Makwana, Dr. Pankaj Patel, who have been my teachers, Dr. Nadeem Lil, University of Wisconsin and University of Colorado, where I did my research fellowship and spine fellowships after my surgical residency at NHL MMC. Okay, coming to the topic. Our agenda for today would be materiovigilance and its significance, categories, medical device reporting, what exactly is to be reported by a particular surgeon or an orthopedic surgeon, instrument description, usage and safety, and correct handling of the instruments. So what exactly is materiovigilance? When you talk about materiovigilance, Okay, so materiovigilance. So the purpose of materiovigilance is to study and follow incidents that might result from using a medical device. So basically, there are n number of devices which are coming to the market. I'm pretty sure the friends of mine who are listening to the talks are surgeons and dealing with a number of implants. They have implant companies coming to them every day and telling them to use their implants, which may be indigenously made without any certifications, and it might prove to be dangerous for the patients when they are applied to it. So it enables dangerous devices to be withdrawn from the market and eliminate the faults in the medical devices. So when we talk about the categories, we divide the materiovigilance into 4 categories. Class 1 being the least likely one which can cause any harm. For example, contact lenses. They do not cause harm to the body, but yes, they can reduce the eyesight. And class 3 and 4 are the most likely causes, which causes severe mortality or morbidity in the patient. For example, cardiac pacemaker that we have. So the cardiac pacemaker can lead to the death of a person if it is not properly validated and not properly tested before coming to the market. So what exactly is medical device reporting? Medical device reporting is reporting of an adverse effect with a particular medical device, and a vast majority of medical device reports are related to medical device defects or failures. And it is the obligation of the surgeon who is using a particular medical device or an instrument or a surgical implant, and if he sees that these implants are causing some kind of harm to the patient, it has to be reported. It just can't be ignored, because the same implant might be used by someone else, or it may lead to a harm to the body of that patient. So what exactly is to be reported? When we talk about reporting in any dysfunction or any change of the characteristics or any inadequacy in labeling or instructions that might lead to a failure in the treatment of the patient, any technical or medical reason related to characteristics, and the cases where there are serious incidents, which I'm about to tell you in a few examples that we follow, they have to be reported as soon as possible to the concerned department, as mentioned in the talks earlier. There are lots of basic orthopedic implants. I believe there might be orthopedic residents who might be listening to this talk, and they must have even experience. We have tibia nail, femur plate, tibia plate, radius plate. But whenever we talk about the Asian population, a lot of these implants, what we use in India and which are FDA approved, are made for the Western population, and we have been using it for the Indian population. So there are a few companies who have come up with their implants in India. However, they are not FDA approved. They give the doctors and the patients at a cheaper rate, and many of the surgeons are using these implants without validation and without reporting. And you see, when they are not properly customized and validated, there is a breakage of the screw, there is a breakage of the nail, there is a breakage of the plate. and there is no standard hexed or screw removing instrument which is available. For example, you have a locally Gujarat made implant which you are putting in a patient, and then that patient migrates to US, and the patient has a broken femur nail, and you don't have proper instruments because it is not validated, and any issues in removing of the screw has not been reported, then what the patient results in is a surgical failure because the doctor does not have proper instruments to remove that implant. Now, in a few slides, I am about to tell you some of the recent innovations that we are working on. A lot of my surgical friends might be getting these uh, as representations in their clinics, and the people telling them to use these innovations. However, whenever you use them, it is very important that these needs to be validated, and any issue faced during their usage should be properly reported. So one of the innovations which has been come up is an epidural stimulator. So epidural stimulator is a device whenever we have a spinal cord injured patient or patients who are not able to move their limbs, let's say lower limbs, the stimulator can be put on the spinal cord. It generates electrical sensations. These electrical sensations have the potency of moving your lower limbs. However, this device, though has been made, has not been properly validated. There are n number of institutes, there are n number of organizations in India who are preaching this as a treatment modality, but nothing is a treatment modality unless and until it is validated. So any of my friends who have been using this epidural stimulator in their practice, please note that in case you come up with a problem with the epidural stimulator, let it be twitching, let it be any problem in the skin, any surgical problem, that has to be immediately reported so that the condition could be improved of this instrument and it could be used. Another thing which is of great discussion these days and a hot topic is the diaphragmatic pacer. And I'm pretty sure a lot of the people who are from emergency medicine dealing with the patients on ventilator every day might be listening to it and might be attending conferences. A few places have been using this diaphragmatic pacer very actively, but still there is not a validated study by which we can say that this is the device to be used. Plus, if you are using it in your hospital practice, in your ICU settings, and you find that there is a problem in this diaphragmatic pacer, it has to be reported immediately. So this pacer basically stimulates the diaphragm, and the people who have high cervical injuries, C1, C2, and spinal cord injuries, this is of immense benefit by moving the diaphragm of the patients and helping in the respiration. Robotics in surgery has been known since a long time. There are two kinds of models that have been reported. Let it be Da Vinci model or the Zeus model. I'm pretty sure all the surgical friends who are listening to the talk are aware of this model and how these things well coordinated when a surgeon sits on the computer and he operates on the patient. And the second Zeus model where the action of the wrist and fingers take place simultaneously. However, these things are being validated. Any problem in such instruments need to be reported ASAP. You might be a perfect robotic surgeon, but any problems with the instrument has to be reported as soon as possible. Or my orthopedic residents have been using C-arm since a long time, and a lot of my friends, especially in NHL, we had used navigation there, especially for TKR, and I'm not sure if they have incorporated in spine surgeries or not. But C-arm and navigation has been used since a long time. However, O-arm is relatively a new technique, and a number of companies are working these days who are trying to build artificial intelligence into this C-arm and O-arm to reduce the exposure. To quote an example, you take an image of the back using the C-arm or O-arm, and you don't know what exactly level is there. So what you end up doing is you screen the whole spine using the C-arm and find out a particular level. Okay, this is L4 or this is L5, and this ends up in resulting a lot of exposure to the doctor and also to the patient. So these companies, what they are trying to do is they are trying to build artificial intelligence to the C-arm and O-arm, and it reads the level and it informs the surgeon like this is the exact L4 or L5 level. But now the question comes here: you have been using this artificially intelligent machine of C-arm and O-arm. It tells you that it is the L5 level, and you operate on the L5 level, and then you realize that it is the L4 level, and the machine was wrong. See, this is not validated, and if you do not report this thing and the patient got operated at a wrong level by the artificial intelligence of this machine, then there are n number of patients who will be operated in a similar manner. So if you come up with such problems, it has to be reported as soon as possible to the concerned agencies, and the developer needs to be penalized or told that the rectification needs to be done. VR and AR is being increasingly used these days in order to rehabilitate the spinal cord injured or the osteoarthritis or orthopedic patient. So it's a simple game in which what we do is we provide the patient with a game, let's say a Pac-Man. I have a patient of wrist fracture and metacarpal fracture, and I tell that patient, okay, first option is you go to a physiotherapist and she does all kinds of exercises. Maybe the patient got bored with that physiotherapist. Then what is the option? The second option is you provide the patient with a game using a virtual reality or an augmented reality, and then you tell the patient, okay, this is a Pac-Man game, and you have to catch all those things and eat it using your hand. So this becomes less boring and less monotonous for the patient, and patient does all these exercises. Now, these things are increasingly being used. I'm pretty sure a lot of my orthopedic friends are being approached by these companies who are using this augmented reality, virtual reality in rehabilitation. But if this game is just serving the purpose of game and it is not helping in strengthening your extensors, flexors, or whatever exercises for the knee, and it is not doing those exercises, it has to be reported and not just used for without purpose. So this reporting has to be done. Brain machine interface is also a technology which is very in these days. Things are being developed, and in coming 2-3 years, a lot of my friends will be contacted for this. So I had an opportunity to visit and work with National Brain Research Center in Manesar. So what exactly they're trying to do is they use a spinal cord injured monkey, a monkey who has an injury in the neck, and the monkey is sitting and the brain signals are being used, is being read using MRI or using brain machine interface, let's say EEG. So if the monkey wants to lift a banana, which is from the right hand, there are particular signals in the brain that get activated. These signals are read by the machine, and an arm, which is a robotic arm, goes and picks that banana. So this is a very in thing and is of immense use for the patients who are spinal cord injured, who are not able to move their hands, are not able to move their legs. But the signal interpretation has to be correct. When we talk about it, it seems very interesting. When we talk about it, it holds a lot of future. But yes, if an action is proved wrong, is read wrong by the brain machine interface machine or an EEG or an MRI, it can lead to disastrous consequences. So a lot of my friends who might be going for these things in future in next 2-3 years need to know that any incidents which is harmful to the patient using a brain machine interface has to be reported as soon as possible using the principle of material vigilance. A lot of things are being developed for the exoskeleton, artificial muscle, robotic hand, soft pneumatic muscles, and even wheelchairs. We have standing wheelchairs. We had a news of a surgeon who got paralyzed because of an injury in the back, and he operates using a standing wheelchair. So these are n number of devices which are being developed and are coming to the market, but proper validation is required. And any problem noticed by the doctors, by the surgeons, by the physicians, by anyone needs to be reported as soon as possible. However, an important thing that we need to keep it in our mind is not all failures that we see in surgery or during surgery are because of the fault in the surgical instruments. There are faults which happen because of the side of the surgeon, and they do not need to be reported as a fault of the instrument or the implant. So when we talk about it, there are n number of minor instruments that are used both in surgery and both in orthopedics. Let it be suction tubes, biopsy needle, knife handles, burr, saw, osteotomes, drill, screws. I will talk in next 2-3 slides a few of the instruments which have been shown to be failure, but they were on the part of surgeons, and we need to keep this in our mind as a surgeon that these things need to be properly dealt with and to be done. A very simple example: all the friends who are in the surgical field and the emergency medicine and have been using scalpel, the proper way of using scalpel, our teachers have been telling this during our internship, during our residency, but still there are surgeons who use scalpel in the wrong way, which is shown in the red and a cross mark here. So that has to be always kept in mind. Any failure, any harm in the surgery because of this maneuver will be a fault of surgeon and not because of the instrument. Similarly, when you put a stab in the skin, you have to always remember you have to use the other hand to stretch the skin and hold it tight. If you make a direct stab, or if you make a cut by putting a stab, it can go inside and injure a vessel or a nerve. So that has to be always kept in mind. There have been incidents in which the knife handle has cut the fingers of the surgeons or the nurses. It is not the fault of the scalpel. It is not the fault of the knife. It is the fault of the practicing nurse or the surgeon who removed the blade using hand. It is to be remembered that the blade is never to be removed with the hand, and it has to be removed using an artery or using a needle holder, maybe, if you do not have an artery. Another important thing is holding a needle, a very common mistake. Our surgeons and our friends have been telling it since our internship. The needle has to be held in the correct manner as shown here from 2/3 and 1/3 distance. Because if you hold it in a wrong manner, it toggles while suturing the skin. And when it toggles, it can even injure you, and that will be your fault and not the fault of the needle. So if you report it, you will be considered as wrong and not the fault of the instrument, because this instrument has been rightly validated and being used since eternity. Another thing is scissors. You use it using your ring finger and the thumb. You do not use the index finger or the second finger to hold the scissors whenever you do surgeries, because whenever you use the ring finger to hold it, you can easily make the incisions and the cuts, and these two index finger can be used to properly guide the way where you have to make the incision. Dissecting forceps is to dissect the areas, not to crush the tissues. There have been reports in which tissues have been crushed because dissecting forceps has been used to hold the tissues to vessels, and it leads to the damage of the vessels and the tissues. So always remember, any damage to the body is because of your wrong handling and not because of the instrument. Similarly, hemostat, the right method of holding it is again using the ring finger and not the index finger. Whenever you hold it with these two fingers, it has to be held. Another common thing, cautery. A lot of my surgical friends have been using cautery and maybe overusing cautery whenever there is bleeding. So we all know that there are 2 points in the cautery. One is for cutting and one is for coagulation. And it has to be always remembered that where you have to use cut and where you have to use coagulation. Excessive burning of tissues will leads to high infection, and it is not fault of the cautery. It is the fault of the surgeon who is using excessive coagulation in all these areas. The cutting area has to be used for cutting, and the coagulation has to be done for coagulation. So I'd like to say one thing, that whenever we talk about all these innovations which are coming up, there are any number of innovations which are coming up, even in emergency medicine, surgery, orthopedics. There's a one thought that we should always keep in mind, that intuition is the master and proof is just a slave. It's a mean to convince that you were not wrong. So start intuiting, start innovating, start inventing. But whenever you start inventing, there's one thought that we have to always remember, and I'm pretty sure all my friends, especially from NHL, have been told by their mentors and the teachers since always, that we have one single aim, that is do no harm. You must be coming up with amazing instruments, amazing innovations, amazing rehabilitative measures, new instruments for surgeries, new implants, but it has to be always remembered that the instrument that you make, the instrument that you innovate should not cause any harm. And if you feel that it is causing any harm, it has to be right away reported to the concerned authority to prevent any kind of future damages to the patient. With this, I conclude my talk. This is my email address and phone number. If anybody wants to get in touch with me regarding any innovations or any future prospects, that is the website in which you can know about other future modalities or whatever you like to connect with me. Thank you so much. Thank you to the organizers.